Since 2007, assessment of competence in the workplace has been through workplace-based assessments, or WBAs. These will be familiar to you and include the PBA, DOPS and KEX. These assessments are very good at assessing performance in a particular operation or discussing management of a particular condition, but surgery is of course more than that and integrates lots of tasks, often at the same time, to perform well in managing the acute take or managing outpatients, for example. The GMC recognise that assessments are often too detailed, too granular, and centred on tasks too small to make an overall judgment about how a trainee is performing in the workplace. If you think of what we do now, and to borrow the construction analogy for learning, the unit of assessment is a WBA. What we do through training is repeat WBAs and placing one on top of the other to build up to being a competent new consultant. However, as we go along we find it difficult to check how the building is progressing. Most of the time everything goes according to plan, but sometimes we end up with something like this. It's undoubtedly a house. It's got walls, a roof of sorts, windows and a door, but it's certainly not safe. Rather than getting involved in each small brick, we need to be able to stand back and see the end product of training during training and aim towards that. In Excellence by Design, published in 2017, the GMC described a set of standards for curricula and recognised that assessment at present is too granular. To address this, they require that new curricula become outcomes-based, that is, you finish training when you've acquired the competence to safely become a day one consultant in the specialty, and that these curricula describe fewer, high-level, generic, shared and specialty-specific outcomes. These high-level outcomes are known as capabilities in practice, or CiPs. So if training's outcomes-based, what's the outcome? Well, it's whatever's needed to be a safe day one consultant. With reference to the syllabus and from your professional experience, you know what's required to be a day one consultant in your specialty. It's quite hard to meaningfully describe it without breaking it down a bit first. So what makes up the essential large tasks of a consultant surgeon through the week? We can break what we all do down into 5 main areas. Managing an outpatient clinic, managing inpatients and ward rounds, managing the acute take, managing a theatre list, and multidisciplinary working in a formal MDT or outside of one. Each of these discrete areas of the working week combine to make the overall job, so if you can do all of these to a level of a day one consultant and have met the generic professional capabilities, then you're ready to complete training. Each of these areas is a high-level outcome of training and is known as a capability in practice. These 5 CiPs are common to all surgical specialties. Cardiothoracic surgery, paediatric surgery and plastic surgery have also described some extra areas for CiPs that are central to the safe practice of those specialties. Each CiP integrates a lot of different tasks and requires combinations of knowledge, clinical and professional and technical skills to produce a functioning whole in each CiP. For instance, to manage the acute take, a surgeon needs to be able to communicate effectively with primary care, patients, the multidisciplinary team in surgery and colleagues from other specialty. To have the ability to take a history and examine the patient, the knowledge to formulate a differential diagnosis and decide on what test to perform, and to draw on knowledge and experience to develop a plan for treatment and have the technical skills to operate safely on that patient if surgery is required. I'm sure you think of lots of other examples of what's required to safely perform each of these CiP areas. The details can be as fine as you like, but what is important is that you're able to make a holistic, professional opinion about the performance of a trainee relative to what's expected of a day one consultant in each of the CiP areas. We will show you how we will help you to do this, record your professional opinion and give constructive and relevant feedback to trainees in our video on the multiple consultant report. In summary then, we're moving to an outcomes-based curriculum. The end of training comes when a trainee can safely act as a day one consultant. We have to describe some shared outcomes, and these are large areas of the job that we want to do each week and are known as capabilities in practice. Using holistic professional opinion about performance in each of these areas relative to what's expected of a day one safe consultant will allow us to move away from granular tick box assessments to one where we can keep the end point of training in view at all times and always be able to see the big picture clearly.